Having fluctuating blood pressure can put you at a greater risk of several health problems like heart attack, heart failure, stroke, etc. So to aware us regarding this, we have our next speaker with us, Dr. Sudeb Mukherjee, a young and renowned cardiologist practicing in Kolkata. And to chair this particular session, I'd like to invite Dr. Vishwajit Banerjee, one of the senior most medical consultant, and Dr. Mridul Bera, he is not here. Okay, sir, please introduce our speaker. Dr. Bera will join shortly.
Speaker of this penultimate session is Dr. Sudeb Mukherjee. He is a very energetic and young cardiologist. He is MD-DM and attached to B.M. Birla Hospital. He will talk about BP variability and target organ damage. So I'll request Dr. Mukherjee to start his deliberation.
Hello, good evening everyone. The topic of discussion today is blood pressure variability and organ damage. After a fascinating discussion on varicose and heart failure, we are here in basics. We are here in basics to discuss about the blood pressure variability. We all know the systemic hypertension. Yes. Systemic hypertension is a very prevalent disorders affecting worldwide. And here we are to discuss about the blood pressure variability. I won't take any extra time, rather I will be very precise and specific. What I'll be talking about today is the hypertension and the cardiovascular risk. Where do we stand today? Variability of blood pressure and cardiovascular risk. Key considerations for variability of blood pressure, organ damage, and prevention of treatment little bit. So where do we stand? We all know that the blood pressure is the leading risk factors for global burden of disease, and it is responsible for 69% of first myocardial infarction, 74% cases of coronary heart disease, 77% of first strokes, and more than 90% cases of heart failure, set aside arrhythmia. That's a huge burden. Even if we talk about the premature cardiovascular disease, the global burden estimates that by 2025, the hypertension is one of the largest risk factors for development of cardiovascular disease. And by reducing these risk factors only, we can reduce the overall burden by more than 25%. So heart, not only heart, the hypertension affects almost every organs of our body, specifically the endothelium. It affects the brain, causing hemorrhage, stroke, dementia, affects the eye, retinopathy, affects the peripheral vascular system, the kidney, one of the very important organ causing renal failure, and of course, left ventricular hypertrophy, coronary artery disease, arrhythmia, and heart failure. Therefore, it is very important to reduce the blood pressure to the optimal level. It has been seen that 2 millimeter mercury of reduction in the systolic blood pressure reduces 7% overall mortality in ischemic heart disease and almost 10% reduction in the risk of stroke. So the benefit of blood pressure control is huge. 10 millimeter mercury reduction of systolic blood pressure is associated with 50 to 60% lower risk of stroke death, 40 to 50% lower risk of death related to coronary artery disease, and 50% lower risk of heart failure. Greater benefits has been observed with older ages and those who had a higher BP at first baseline readings. If we talk about hypertension in India, there was an article published in Journal of Hypertension 2014 which clearly stated that in rural and urban population in India, 10 to 20% of the patients are actually have a good control of blood pressure. So you can imagine the burden of the disease. If you are talking about CSI cardiac prevalence study, which incorporated more than 181,000 patients in 21 states across India, has clearly stated that 60% of the people are undiagnosed, they are not aware of their hypertension, and 42% of those who are diagnosed are not under control. So definitely, it's a huge burden. So what we are missing is actually not the measurements of blood pressure, rather three important factors. One is BP variability, second is central BP or aortic stiffness, and third is masked hypertension. These three important factors. I will be focusing on BP variability today. So what is BP variability? We all know that the blood pressure normally fluctuates during day, can vary from day to day. Pronounced fluctuation in blood pressure can occur over short or long term. And there is one term called episodic hypertension, which has been seen to be responsible in more than 70% of the cases underlying transient ischemic attack. In fact, only stable hypertension has been responsible around 10 to 12%. So this is very important. Blood pressure variability is difficult to measure in routine clinical practice. Unfortunately, no clearly defined or widely adopted diagnostic definition or treatment goals are there. So if we see the normal 24-hour BP, then we will see that during the night, the normal BP falls, as you can see in this chart. And during the daytime, it gradually first causes morning surge and then as an average BP. So basically, BP may fluctuate more than 20 millimeter of mercury during a 24-hour period, and it is typically lowest during sleep. So this physiological variation can be affected by lot of factors, be it respiration, ventilation, emotion, exercise, meals, taking food, tobacco, alcohol, pain, temperature, and circadian rhythm or diurnal variation. There are interesting observations in this overall estimation of 24 hours blood pressure, that with age, the systolic and diastolic blood pressure gradually increases. It is more in cases of male compared to female. Regarding circadian variation, the blood pressure remains low during sleep and highest in the mornings, increases transiently during any physical activity, muscular exercise, any mental stress, or emotional excitement. And the effect of gravity is very important. When we are standing, the blood pressure in any vessel varies with the vertical distance from the heart. There is another term called BP reactivity. It is defined as the response to environmental stressors, usually quantitated as responses to standardized laboratory stressors. There are hot reactors, very difficult to quantitate, however suspected to be predictive of future development of hypertension and cardiovascular risk. There is another term called BP levelity, which is very characteristic of human blood pressure. There is again no clear definition that differentiates normal from abnormal levelity. We often use the term levile hypertension, widely used, but lacks an accepted definition and more of a clinical impression rather than substantial any specific diagnosis. However, it is likely due to sympathetic overactivation and usually falls without any intervention. Risk of hypertension in future, but no role of pre-treatment. So, circadian rhythm that we are aware, the observation is that the subject whose 24-hour variability is higher compared to a different average group is more likely to have target organ damage. Hypertensive women with a blunted nocturnal fall that is normal in blood pressure, that we know as a non-dippers or reverse dippers, likely to suffer morbid cardiovascular events than the deepers. An antihypertensive treatment that reduces blood pressure variability and preserves the nocturnal fall in blood pressure will help to protect target organs in hypertension. It has been seen, if we see the chromobiology of this particular several cardiovascular complications like sudden death, acute myocardial infarction, typical angina, silent ischemia, total ischemic burden, ischemic stroke, then we'll see that the most of these incidents actually happens between in the morning 6 o'clock to 10 o'clock. So relationship to high morning surge, increased catecholamines, and maybe some other factors like stickia platelets and high heart rate may be responsible, but important factor is this morning surge, which may be responsible for these typical morning events. So as a whole, if we talk about the types of BP variability, this slide is very important. You can see there may be very short-term blood pressure variability, short-term, mid-term, and long-term, and all actually underlies with a central sympathetic drive, arterial or cardiopulmonary reflex activity, humoral, rheological, behavioral, and emotional factors, decreased activity or sleep, stiffness of the artery, very important factors, and improper dosing or inappropriate titration of the antihypertensive drugs that may ultimately lead to increased BP variability. So these all ultimately lead to subclavian organ damage, increased cardiovascular events, increased renal damage, increased cerebrovascular accident, and some other organ damage. Therefore, it is very important to control the blood pressure variability. Over the years, there has been a lot of studies. The summation of the several studies in meta-analysis form was published in the Nature Review of Cardiology, which clearly stated that 24 hours blood pressure variability and target organ damage are very, very interlinked. This cross-sectional evidence clearly shown that more than 20 millimeter mercury of this blood pressure variability is associated with increased organ damage, not only in the cardiovascular system, but also in the kidney renal function deterioration. Therefore, blood pressure variability and cardiovascular risk is definitely one of the important factors. So what we are missing actually is the out of clinic blood pressure recording that can categorize, that can diagnose a large amount of patients who are actually masked hypertension, and a normotensive patients who presume to be normotensive, not actually normotensive, basically non-dippers or reverse dippers. They have the propensity of development of increased cardiovascular mortality and therefore need to be within the same umbrella that we are treating. Regarding nocturnal hypertension, we all know that more than 20% is extreme dipping, between 10 and 20% is a normal pattern, and less than that is a non-dipper, and sometimes there are reverse dipper. So non-dipping and reverse dipping is associated with increased risk of organ damage, brain, heart, kidney, and increased cardiovascular events and mortality. So this is the chart that how it looks like in ambulatory blood pressure management that you can see. The problem with this nocturnal hypertension may be due to several factors, be it increased fluid volume like in heart failure, renal insufficiency, sleep disorders, autonomic dysfunction, neuropsychiatric disorders. Therefore, it is very important to control the blood pressure variability. There is one interesting observation that was published in Nature Review Cardiology that has clearly stated that the sleep time blood pressure may be a prognostic marker of type 2 diabetes and therapeutic target for prevention. Very interesting observation and study. They incorporated almost 2,656 volunteers of this, and they were followed up for almost 6 years, and followed by that 190 participants had developed type 2 diabetes. The conclusion was that it was the first kind of a study to be suggested by the researchers that lowering sleep time blood pressure could be a novel method for reducing the risk of new onset diabetes. And the message was clear. In their study, the diabetes risk fell by 57% in patients taking medications before bed. So how to tackle? The technique is basically of reducing blood pressure variation, first to rule out measurements error, and second, self-monitoring of blood pressure. That is very important. Not only self-monitoring, but also to incorporate home BP measurements and ambulatory blood pressure measurements. in almost all the guidelines, it has been incorporated as a class 1 recommendation to go for HBPM and ABPM, not only in naive patients, but also in those patients who are receiving antihypertensive therapy. And ABPM is recommended in some high-risk groups also, because clinical suspicion of organ damage or any established clinical event is very important factors to uptitrate or intensify your treatment. There are asymptomatic hypertension-mediated organ damage, and to know, you may go for several diagnostic tools. First of all, for arterial stiffening, you can measure simply a pulse pressure, which if it is more than 60 millimeter, or you can go for carotid artery pulsation. ECG is a very important tool which can clearly delineate the left ventricular hypertrophy by the voltage criteria. You can go for echocardiogram, which can clearly see if there is LVMI is high or not. You can go for urine ACR to see for microalbuminuria. You can estimate the EGFR, and one important parameter is ankle brachial index, which can clearly see that whether you are suffering from any peripheral arterial disease or not. And of course, the eye checkup is mandatory to look for your retinal changes as a organ damage. In cases of established cardiovascular disease, definitely we have several imaging tools for cerebrovascular. For arterial, we have definitive investigative tool for peripheral arterial disease, and for atrial fibrillation, we have several monitoring systems. But for HMOD, that is the hypertensive-mediated organ damage, in ESC guideline, they have a clear-cut score. We call it a HEART score system, that is systemic coronary risk evaluation, which can clearly delineate 10-year cumulative cardiovascular risk and therefore helps to intensify the treatment. It is from the European Society of Cardiology score. We call it a European risk chart based on low risk profile or high risk profile. It also incorporates other factors like lifestyle, your smoking habits, your family history, your genetic factors. Along with that, you can incorporate a lot of other investigations like ECG, urine ACR, echo, carotid ultrasound, abdominal ultrasound, renal artery Doppler, cognitive function testing, and brain imaging. And all can help to ultimately accumulate the patient's overall risk category to intensify the treatment. Coming to the therapeutic consideration, the latest guideline as per the NICE and ESH clearly state that updated guidance recommends the best available evidence-based treatment options to suppress the blood pressure variability in people with hypertension. Therefore, now it is quite understandable. I'm not going into the details of several trials that you can see here, ASCOT trial, ACCOMPLISH trial, who has shown some of the benefit with some particular class of antihypertensive over other drugs. But what is very clear is that the benefits beyond normal blood pressure control. The blood pressure variability control by 2.7 millimeter of mercury can significantly affect the reduction in the coronary events in the range of 4 to 8% and almost more than 10% in cases of strokes. Therefore, it is very important to choose your antihypertensive clearly. In some of the studies has clearly shown that the calcium channel blockers are very important to reduce the blood pressure variability. There are some studies which has clearly shown significant improvement with some classes of antihypertensive over others. But what I would like to say is the synergism. Synergy is the most important factor. Combination of different classes of antihypertensive to have the best results is the first choice for controlling the blood pressure variability. And most of the time, this combination can be achieved with the calcium channel blockers and a combination of RAS blocker, that is ACE inhibitor or ARB, and that can significantly reduce the blood pressure variability. So to conclude, the blood pressure variability should be considered as a goal to guide choice of initial antihypertensive treatment, and the mean blood pressure should be monitored as it is a potential marker for blood pressure variability. Synergism between long-acting antihypertensive are crucial to maintain optimal blood pressure sustain. With this, I conclude this session. Thank you very much.
Thank you, Dr. Mukherjee, for your kind, excellent deliberations. So, I will ask one or two questions from the audience.
I'm Dr. Shah speaking. So with respect to blood pressure variability, is there a low blood pressure that you don't want to hit? Well, because coronary artery perfusion might be affected. or does it not matter?
Actually, the initial concept was like cholesterol, the more low, the more better. But if we talk about the Spain trial that was actually halted immediately, prematurely, which targeted less than 120 by 80, they had experienced some of the problems when the blood pressure went below 100. So therefore, the very tight control of the blood pressure is not recommended because it might hamper, as you have correctly said, regarding the CPP, regarding the myocardial vascular bed perfusion. But we do not have any robust data that what is it exactly. You know, we have seen a lot of patients of heart failure who are quite okay with 90, 95 systolic blood pressure. So you are never sure which blood pressure is very low. Yes, of course, if the patient is symptomatic, having some issues, and in the form of microvascular damage, we can have FMD, flow-mediated dilatation, or any other microvascular changes, be it in form of any brachial parameters, any acetylcholine-induced parameter, that is in technically experimental models, then we can be sure that the particular blood pressure is very low. Otherwise, there is no such. Apart from being symptomatic, then you have to think that we might reduce the blood pressure drugs that you are using.
So, Dr. Mukherjee, just like we are using the CGM for the glycemic variability, we assess the patient is around the target range is time in range the patient should keep is around 70% of time, and hyperglycemic range is around less than 20%, and hypoglycemic range is less than 5% of the time. So do you have any idea about how we can go with the blood pressure? Because Sarah's already told about the patient maybe and
yes,
sometimes experience hypotension. So this is my first question, if there is any data about it. And another question is in the pre-hypertensive population, or this BP variability again is considerable as a bad prognostic marker in the future.
Well, to answer your first question regarding this, that we do not have any such parameters by which we can say, but definitely we can go for ABPM and home BP measurements. ABPM can clearly says that whether the mean BP or your lowest BP is below that what we are thinking about, maybe 90, or sometimes in sleeping BP, the latest guideline 110 by 65 as per the ACC and ESC. So if it is below 110 and 65, then it is okay. But there is no guideline regarding the lowest BP so far. Well, regarding your second question that how it should be, we can go ahead. There is no such data regarding the pre-treatment, I mean the normal blood pressure or the pre-hypertensive blood group where we should initiate pharmacological treatment. Lifestyle modification, regular exercise, diet control is the first choice. But unless and until you fall in that particular category, you must not initiate the pharmacologic therapy so far. The current standard is 120/80, 120 to 139 is the pre-hypertensive, but still you can choose for, unless the patient is diabetic, you can choose for lifestyle modification. If the patient is diabetic or have any clinical ASCVD with a risk score more than 10%, then you should initiate treatment. Otherwise, in cases of BPV with this kind of category or borderline BP, like episodic hypertension, there is no recommendation for initiating treatment. Just by 1 or 2 BP recording between 120 to 130 without any risk factors or clinical ASCVD, there is no point of initiating pharmacological treatment from the very first. That's all I think.
I don't think there is any other question, so I conclude this session. Thank you so much, Dr. Mukherjee.
Thank you for this wonderful session. Can I ask Dr. Bera to felicitate Dr. Mukherjee, please? And can I ask Dr. Sanjay Shah to felicitate? Yeah, okay, right, yeah. All right. we had a wonderful scientific day today, and we are hoping to see tomorrow everyone at about 9 p.m., 9 a.m. tomorrow. And thank you very much. Thank you very much for being here. Have a nice evening. Thank you. And we are hoping to see tomorrow everyone at about 9 p.m., 9 a.m.